This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. I'll just start out with a reminder. Next week, our speaker, we have an outside speaker, Dr. Kim Eagle, is going to be visiting us from the University of Michigan. I encourage you to attend that one. Kim's a great speaker. It's also a remind you that next Monday is graduation, so come early. Traffic will be building probably about the time we start. So this morning, we have Dr. Tanveer Rab with us today. Tanveer is Associate Professor in the Division of Cardiology. Tanveer did his residency at Henry Ford and did his cardiology fellowship here. Has been on the faculty for a little while, I don't know, 8 years, 9 years, 8 years? 9, 10 years, 20 years, 30 years. How long have you been on faculty, Tanveer? 1998. And Tanveer is one of our interventionalists who also does a fair bit of general cardiology, and he's going to talk to us today about mechanical LV support in the Cath lab. Dr. Rab. Just giving me a hard time.
Yeah, that's okay. That's all right. Good morning. Some of you might have heard this talk at EPIC, but this is an expanded version of it. I'm going to talk to you about mechanical LV support in the Cath lab and a suggested algorithmic approach. I'll tell you that I'm a part of a working group in the college where we're trying to define or create an algorithm for these devices. And obviously, as many cardiologists as you have in that kind of room, there's no consensus. So we have no conflict of interest in this. So cardiogenic shock is defined as hypotension with systolic blood pressure less than 90, end organ hypoperfusion with cool extremities and urine output less than 30 cc's an hour, a cardiac index of less than 2.2, and a wedge pressure greater than 15, which is somewhat strange because that's what the SCAI and ACC defines it, the wedge pressure greater than 15. I thought more than 20, 25 would probably be something that you should think about in terms of shock. And a mixed venous blood oxygen saturation less than 65%. Majority of cardiogenic shock is due to acute LV failure, 75% of the time. And it's a matter of other things, but predominantly acute LV failure is the cause. And that is due to LAD territory occlusion or the last remaining conduit leading to the left side of the heart. So predominant LAD occlusion or the last remaining conduit to the left side of the heart. And generally shock develops about 6 hours after the onset of chest pain. Cardiac arrest, we have a publication coming out in the guidelines soon, but this will be about poor prognostic indicators are generally continued CPR, continued constant CPR more than 30 minutes, a pH of less than 7.2, a lactate greater than 7. You know, the neurological outcomes after these parameters extremely poor, and survival is absolutely none. I want to tell you that there's no consensus of what defines high risk or when to use a mechanical cardiac support device, as FSCAI calls it, or College of Cardiology calls it. Again, there's no consensus. Percutaneous cardiac assist devices, or which device to use and when. And agreement on using these devices as early as possible, but there is agreement that these devices should be used as early as possible in cardiogenic shock or cardiac arrest, or with large infarcts, and prophylactically in high-risk patients. And there's recognition that most of the world has a balloon pump, and these expensive devices are generally not available in most countries, even in most industrialized nations. For example, in Europe, Germany just goes with its own set of devices, whereas France goes with another set of devices, and China, balloon pump is the only device available. So balloon pump is the only device that's currently available, though I'll show you data that the current next generation higher-end devices are probably more beneficial for the patient. This is from JACC Interventions of Heart in February, defining what is high risk. So high risk is cardiogenic shock within 24 hours or the start of coronary intervention, LV systolic dysfunction, the EF less than 30 to 40%, KILIP class 2 to 4 on presentation of CHF, resuscitated cardiac arrest within 24 hours, STEMI, acute coronary syndrome with unstable hemodynamics, dysrhythmia or refractory angina, mechanical complications, acute myocardial infarction such as mitral regurgitation, older age group, and comorbidities such as previous stroke, renal dysfunction, chronic lung disease. Anatomic criteria are unprotected left main or left main equivalent, multivessel disease, distal left main bifurcation, previous coronary artery bypass grafting, last remaining conduit, a target vessel supplying collateral to an occluded second vessel that supplies up to 40% of the myocardium. And hemodynamic criteria is what we went through a minute ago. The four devices currently available in this country, of course, are the balloon pump, Impella, TandemHeart, and ECMO. What is the goal of LV support? Goal of LV support is support, okay? Nothing more than that, provide support. To maintain vital organ perfusion, thereby preventing systemic shock syndrome, reducing cardiac filling pressures, thereby reducing congestion of pulmonary edema, reducing left ventricular volumes, wall stress, and myocardial oxygen consumption, augmenting coronary perfusion, and supporting circulation during complex PCI and EP procedures, and trying to limit infarct size. It does not treat the primary cause of shock, okay? Primary cause of shock still needs to be treated so that the patient can survive. So going back to pressure volume loops, it's very important that we understand that and the concept of using these devices. This is so pressure and volume. This is LV systolic pressure, LV end diastolic pressure. This is between 1 and 2, the phase of diastolic filling. This is between 2 and 3 is isovolumetric contraction of the left ventricle. This is the systolic ejection period where the blood ejects from the left ventricle. And at this point over here, the aortic valve tries to close back down, and this is a period of isovolumetric relaxation. Now, in acute myocardial infarction, the end diastolic pressure goes up, systolic pressure goes down. The stroke volume, which is between these two margins, or the area of LV work, this is stroke volume, actually shrinks in size. And the slope of Emax, which is the contractility of the left ventricle in stable condition when the ventricle is not filling, actually the contractility of the ventricle goes down substantially. In cardiogenic shock, again, the end diastolic pressure is increased, systolic pressure reduced, stroke volume is markedly reduced, and LV work is substantially diminished. When you use a balloon pump, for example, if this is the resting stroke volume, what the balloon pump does is reduces systolic pressure, reduces diastolic pressure, but actually the stroke work actually increases by the balloon pump. Contradictory to what we've been taught, the balloon pump actually rests the heart. It actually does not rest the heart. It does improve coronary perfusion, but the workload of the heart actually increases, and the heart has to compensate by increasing systolic volume, also increasing stroke volume. And if you add inotrope and other agents, that work gets harder. So the heart actually does not rest with the balloon pump. And I'll show you data to show that that's the reason why the balloon pump has not been effective. In percutaneous LV support devices, such like the Impella and TandemHeart, you actually rest the heart. You take the workload off the heart. You do decrease the systolic and diastolic pressures within the ventricle and reduce the stroke volume, thereby reducing the work of the heart. Okay, and the heart actually rests. With ECMO, you actually increase both the end diastolic and as well as systolic pressures, but the work of the heart is actually reduced. This whole idea is about reducing the work of the heart. You've got to reduce the work of the heart so the heart can rest. The balloon pump cannot do that, but percutaneous support devices tend to do that. All right, so let's go through the devices. With the balloon pump, the augmentation is low, 0.3 to 0.5 liters per minute. Impella, 2.5 Impella is about 2.5 liters per minute. The new Impella CS goes up to 4 liters per minute. A TandemHeart is about 4 to 5 liters per minute, and ECMO between 4 to 5 liters per minute. Maximum implant dates, the balloon pump can go on for weeks with frequent site changes. Impella is between 6 hours to 7 days. TandemHeart 14 days. ECMO can go on for weeks. Bleeding and hemolysis seen more with all these devices. Particularly, there's more shearing of the erythrocytes with the Impella, so this bleeding risk is higher. Vascular complications are higher with TandemHeart and ECMO because of large size of the cannula. You can see the sheath sizes: 7 to 8 French with the balloon pump, 12 to 14 French with the Impella, 21 French with TandemHeart, 17 to 21 French with ECMO. Balloon pump requires cardiac synchrony. The other devices don't. Insertion of the balloon pump and the Impella is quick by percutaneous technique. You can put both the devices fairly quickly in the cath lab. TandemHeart needs more than an hour. It requires other support personnel, particularly in the unit. And of course, the ECMO requires a perfusionist. Let's go to the intra-aortic balloon pump data. This came out in contemporary trials with the SHOCK 2 trial, where control arm versus balloon pump. Control arm did not receive balloon pump, where another arm received the balloon pump. Patient was shocked. Outcomes were no different. So you go to the recent trials. SHOCK 2, acute MI with cardiogenic shock, 600 patients. Really, there was no survival difference between the two groups. CRISP AMI was another study, no difference in survival between two groups. The NCDR registry of 18,000 patients, no different mortality. And the British study, BCI study, 301 patients, and no different survival. Though at 5 years, there was a 34% reduction in mortality of those who survived with severe ischemic cardiomyopathy and high-risk PCI. So the good old balloon pump really doesn't seem to be effective in acute shock, but this is the device most commonly available in the rest of the world, or most of the world. The Impella device is what we're familiar with over here. It's a pigtail-like device. This sits in the ventricle. There's an inflow cannula. There's a motorized motor sitting here, and the blood is pumped basically from the left ventricle out in the aorta. It does cause reduction of end diastolic volumes and end diastolic pressures. Aortic pressure will increase and flow will increase. Oxygen demand in the left ventricle does decrease, and cardiac power output, I'll come to that in just a minute, actually gets better. If you take the case in point, so for example, the patient has a left main or a high-grade stenosis in the large lost patent conduit, or the patient has a low EF or a myocardial insertion class 4 and not a surgical candidate, and you bring him to the Cath lab for a PCI procedure, for example, if you start with the low pressure and you suddenly inflate the balloon in left main or last conduit, your pressure will drop. Believe me, your pressure will drop very quickly in a matter of seconds, and the patient will crash on you. If you turn the Impella on, for example, you will be able to maintain a pressure fairly smoothly, and this so that you can allow your procedure to take place. You can go on and proceed with the intervention so the patient does not crash. So this is what we see in the lab. The important thing about the Impella is that in the setting of myocardial infarction, for example, with no support versus the Impella, with the use of Impella, the oxygen demand actually decreases. This is absolutely important because the infarct size correlates with oxygen demand during reperfusion. The less the oxygen demand, the less the infarct size. The more the oxygen demand, the more the infarct size, and therefore the Impella, by inference, does help you in reduction of oxygen demand. So going back to the pressure volume loop again, the idea is to unload the left ventricle. The work of the left ventricle is pressure times volume. This area is ventricular work. This area over here is stroke volume. Ventricular work is area of pressure volume loop, and it's proportional to the oxygen demand. Unloading of the work is by trying to reduce this area of the pressure volume loop. If you go back again to compare the balloon pump with the Impella, and if you take the resting state over here, you take the state where the patient is in, what the balloon pump does, it does reduce the systolic and aortic pressure as well as the diastolic, but the stroke volume and the balloon pump, as I explained early on, does increase. Stroke volume increase offsets pressure reduction, actually increases the work of the heart. Impella, on the other hand, unloads the left ventricle, reduces diastolic volume, and reduces the work of the heart. The stroke volume actually decreases. Volume reduction reduces pressure volume loop area and cardiac work. Reduction in cardiac work therefore results in reduction of myocardial oxygen demand. Another concept of cardiac power output. Cardiac power output is a concept that came out of the shock registry, and this was the strongest hemodynamic correlate of mortality in cardiogenic shock from the shock trial registry. Cardiac power output is in watts, and this is mean arterial pressure times cardiac output divided by constant of 451. Normal is less than 0.6 watts. So if you're less than 0.6 watts, your survival is high. In myocardial infarction, it's more than that, you start crashing. So it's a very important concept in terms of shock. It appears that the hemodynamic support effectiveness of the Impella versus the balloon pump, Impella had the least negative impact on reduction of cardiac power output compared to the balloon pump. The other important thing to talk about is PROTECT 2, which is high-risk PCI group, where the Impella was used. Major adverse cardiac and cerebrovascular events were reduced from 31% to 22%, and this benefit was seen up to 90 days post-procedure. Based on this, the FDA just released the Impella 2.5 for high-risk PCI procedures, which included complex CAD, 3-vessel disease left main, patients with depressed EF less than 35%, significant comorbidities, and patients who have been deemed to be inoperable. The next device is TandemHeart. The TandemHeart is a device, again, requires large bore cannulas. A cannula goes through a transseptal puncture in the left atrium. Basically, it takes up the oxygenated blood from here and delivers it via, this goes up the vein to the transseptal puncture in the left atrium. That blood is drawn and returned to the arterial circulation through a motorized pump back through a large cannula in the femoral artery. This, of course, requires expertise in transseptal puncture, and The important complication again of the tandem heart was bleeding and hemolysis, as well as the catheter side trauma and vascular complications that generally would require removal by a surgeon or vascular repair. This is what the tandem heart looks like on an X-ray. And in terms of improvement, the cardiac power output, the cardiac power index actually improved with the use of tandem heart versus the balloon pump. Now, finally, there's veno-arterial extracorporeal membrane oxygenation via ECMO. So basically, there's a conduit in the vein. The blood is extracted from venous port from a vein. It goes through this device, which is a membrane oxygenator. It's actually very small now, returned back to the circulation by an arterial cannula. These cannulas are large, between 17 to 21 French. Large arterial cannula side iliac artery with the via ECMO. There could be distal limb perfusion problems with limb ischemia and require second cannula placement. Surgical explantation is generally required to remove the device with vascular repair, both for the tandem heart and for the via ECMO. And patients with via ECMO are at risk for cerebral hypoxemia due to shunting of blood away from the brain. Another problem with the via ECMO is the ventricle actually dilates and becomes floppy, and sometimes you have to insert a balloon pump just to shrink the ventricle back in size. The ECMO use has in the non-ARDS population in this country has increased by 433%. Okay. However, the survival rates have been marginal. It really very marginal improvement over the years. And again, this is not a destination therapy for patients. You have to be definitive in what you do for the patients. You can help them survive the shock, but unless you do something definitive, the survival benefit is very marginal. The important thing about ECMO and tandem heart is that they require added personnel. ECMO does require a perfusionist that takes up a lot of added personnel time, and the benefits in acute cardiogenic shock and cardiac arrest may not be that great as the data shown. The benefit is in patients who have biventricular failure, with right ventricular failure, or ARDS. Trials of balloon pump and tandem heart and balloon pump with Impella. So the number of patients is sort of small with the balloon pump versus tandem heart and cardiogenic shock and 30-day mortality versus balloon pump versus Impella, or a balloon pump versus tandem heart. Generally, there have been no significant differences in survival at 30 days. LVAD did give rise to higher cardiac index. Legs ischemia was similar in the tandem heart and the Impella groups. Bleeding was more frequently associated with tandem heart and Impella, and hemolysis was significantly higher with the Impella device. So I created this review of contemporary outcomes in mechanical support devices. So in severe cardiogenic shock with refracted balloon pump, with tandem heart Impella, survival 60%, 54% with a complication with severe bleeding and hemolysis. From the US Impella registry with prophylactic high-risk PCI, protective with high-risk PCI, and again with prophylactic high-risk PCI. Basically, you're putting these devices before you start a high-risk PCI procedure. These patients are not in shock or cardiac arrest. Their survival is great, 88%. MACE is lower, and 90 days protective, and prophylactic PCI, again, survival is 87%. But the vascular complications can be high, and there is vascular and acute lung injury with the ECMO or tandem heart devices. In cardiac arrest and cardiogenic shock, the survival is dismal. And just to illustrate that once again, if you put these devices after you've used the balloon pump, your survival is not as great. If you put them in prophylactically, you've got great survival rates. And with, again, going back to cardiogenic shock, cardiac arrest, cardiogenic shock, cardiac arrest, in this particular group from Japan, cardiogenic shock with cardiac arrest and prolonged CPR, look at the survival rates, very dismal. The ECMO registry for cardiac arrest of 2,633 patients, look at the survival rate, very, very low. So you can have improved outcomes if these devices are placed prophylactically early rather than late. So these devices, these newer devices, these devices can cause better LV loading, but they're very expensive. And again, they do increase bleeding. There's more invasive, and the larger bore devices such as tandem heart and ECMO do require vascular repair and explantation procedures. The guidelines in 2014 for ACC non-STEMI or ACS non-STEMI guidelines Basically, it just basically says large amount of ischemic territory with poor LV function. Percutaneous ventricular assist devices can be used for support during the procedure. The 2011 guidelines for PCI is the class 2B indications, and the STEMI guideline for 2013, it still says balloon pump can be used for patients cardiogenic shock after STEMI who do not stabilize quickly with pharmacological therapy. I think this old thinking and old thought, and then it comes to it that alternating LV assist devices can be used in patients with refractory cardiogenic shock. It does not come out clearly to tell you the current guidelines do not specify LV assist devices and when to use them. I want to show you a case that some of our fellows and us I put together, Sunny and Akram, Ayaz. We put this case up for your intervention, and we had a discussion about this in this journal. And what we showed was this patient who came to us with all vessels occluded, right cornea was occluded, the circ was occluded, the LED was occluded, and this patient was in a lot of trouble. We put a balloon pump in, but the patient remained hypotensive despite balloon pump, despite epiboluses and levo-fed. There was absolutely no augmentation with the balloon pump. And this suggested minimal contractility of the LV and lack of effectiveness of the balloon pump. What we went ahead and did was went ahead and put an Impella in. The patient has other devices such as Swan and temporary pacemaker and a lot of other paraphernalia in the heart. And what we were able to show in this particular patient was where the ventricle was dilated over here at baseline. Following this cartoon, we were able to help the patient by improvement in blood pressure. And what this cartoon suggests that a combination of balloon pump and Impella does cause a shrinkage of the LV size, causes it to become more efficient. And a trial of a registry from the US Impella suggested that balloon pump alone may not give you systolic augmentation as a combination of a balloon pump with Impella. Your diastolic pressure may also improve, and the cardiac index will improve as well. So this patient did benefit. He actually got surgical revascularization and survived. Now I'll come to you to a suggested algorithm that I've had in my mind for the use of these devices. This is a very busy slide, but I will break it down in just a minute for you about mechanical LV support in the Cath lab in the setting of cardiac arrest, cardiogenic shock, acute and chronic heart failure, and high-risk PCI. So let me go through each section. So if you have cardiac arrest primarily, or you have cardiac arrest and found to have STEMI, or you come in with acute cardiogenic shock and found to have STEMI, and if the STEMI is large and anterior infarct, the patient has a poor EF and EDP greater than 25. I'm not sure if 15 is the right number. If the EDP is greater than 25, the patient looks unwell to you, and he's in shock with hypotension, tachycardia, he's hypoxemic, and having arrhythmias. Go ahead and put a device in. Go ahead and put a device like an Impella, or we don't use a TandemHeart here. That would be the right thing to do. If the patient is normotensive and non-hypoxemic, and in the CLIP class 1 or 2, probably balloon pump should suffice. If you have cardiogenic shock due to inferior STEMI with RV infarction and the patient is hypotensive, despite IV fluids and inotropes, consider the right side Impella, which has just been released, or a VA ECMO. A balloon pump does not work in this situation because it's a right-sided infarct. For high-risk PCI, a left main 3-vessel disease, a remaining conduit, with an EF, say, of less than 35%, you can start off prophylactically by putting a balloon pump in, and if the patient does not do well, does not have enough support. And the reason I place that here because most of the world has a balloon pump and not these fancy devices. If this doesn't work, you can switch to a 2.5 or 3.5 Impella. If you have acute and chronic heart failure, you can start off with balloon pump and the patient stabilizes. We can place this for patients for chronic use by an axillary approach. And if you have to step up in the balloon pump, you can put a 3.5 Impella as a bridge to LVAD. And you can migrate up to 5 axillary Impella, again as a bridge to LVAD. If the patient deteriorates despite all this, with persistent shock and bileal failure, severe acidemia, CVP greater than 18, elevated lactate, or worsening renal failure, I think you should go to a VA ECMO or TandemHeart. Finally, not to forget access sites. These require that the patient has good leg arteries, okay? And if you don't have these, you cannot really access these large bore devices. There are other alternate sources, and I tell you, this is a patient where we put in a patient who was high risk. We were able to do a left axillary cut down with the vascular attached an 8-minute gel weave graft. and we're able to put the Impella sheath in and deliver the Impella delivery catheter through the axillary conduit. And this move will show you attempts by me to try to move these devices through the conduit. The wire sometimes difficult to move through that connection between the graft and the axillary artery. And you will see the wire will go through eventually. Then we put a multipurpose catheter through on a wire to the left ventricle, put the Impella wire down as a special wire, and then we will deliver the device down. Okay. So I'll end the talk here, and I'll be happy to entertain any questions about what I just presented.
So I'll start out with the obvious question about the cost. You indicated that particularly ECMO is pretty expensive, and I think, I hate to be a little cynical, but what's been driving some of the use has probably been the pretty high reimbursement that hospitals get for ECMO. There's been a lot of interest in bringing it on board at many sites, probably some that are relatively low volume, et cetera. Can you give us a little sense about what costs are for these and what the discussion's been around that?
It is true that the hospital gets more reimbursement value if you put in a Impella ECMO device. I don't know the dollar cost, but I think the device is probably, for Impella, I know it's about $26,000 or so. I don't know, as Bob may know about the surgical cost for an ECMO, but I know the hospital reimbursed with a large amount.
The hospital is very profitable. I agree with Dr. Taylor that the use of ECMO in this country, the 5-time increase in ECMO has driven by reimbursement. If you put an ECMO device in and the ECMO stays in less than 7 days, then the hospital contributing margin is high, up in the $50,000 to $100,000 range. If it's in longer than 14 days, you start to lose money, and then there's an intermediate time. So many hospitals, some hospitals have started using ECMO as part of their CPR team on the floor. If they can't resuscitate the patient quickly, they put the ECMO device in, take them to the CCU, and then sort out what's wrong with the patient. But the cost of the device is probably in the $70,000 range total, and that's for the CardioHelp device, which is the Cadillac device, the smaller device.
The Impella device, generally we've been able to, it's a shorter length device, generally for high-risk PCI. We put it in the lab, use it, generally take it out at the end of the procedure and close the area. And that's very profitable for the hospital. But again, the ECMO and the TandemHeart require take time to take an hour to place. And I think acute cardiogenic shock, cardiac arrest, unless you have a surgical team right there, like some of the other hospitals may have, to have a surgeon there to help you implant it, it does take a little while to put in. Hey, again.
That's very nice, Tanveer. But your point that the purpose of all these things is support, and so then you show pressure volume loops is interesting. But in the cath lab, when things happen, it's not so much support of the heart; it's to keep the patient alive till you can actually fix the problem, which is usually you don't have any blood flow to the heart anymore. So you got to restore. That's how we bail people out. So the question is, I mean, the knee-jerk reaction is somebody closes an LAD and the patient's pressure is dropping. They put a balloon pump in. I mean, is that still the right way to go? Should they put a Impella in right from the outset? Because what you're trying to do here is just keep the patient alive until you can recanalize that LAD and get the patient some perfusion.
I think that that acute abrupt closure in the lab, the algorithm that I showed you, for patients with large infarcts who are coming to you and decide what to do. Acute abrupt occlusion is a very acute event. I think the patient does not have LV dysfunction, he's probably clip class 1 or 2, and you probably can enhance survival by putting a balloon pump in and fixing the problem right away. It can buy you time. If he doesn't get better, at least you have an access to quickly go onto the Impella device. But I think if the patient comes to with a large infarct, is not doing well, is hypotensive, and is in pulmonary edema or really in shock, or has survived a cardiac arrest, I think the right thing to do is to put a support device with an Impella.
Can you go over class 1, 2, 3? It's four is all total.
So class 1 is probably very early shock. It's patients with who are not particularly hypotensive, but could be short of breath with no evidence of pulmonary congestion. Class 4 is extreme cardiogenic shock with hypotension, tachycardia, and profound heart failure. Between class 2 is class 2 and 3 is in between. Class 3 is the one, the classic, where chest X-ray will show curly B lines, etc. And so that's the spectrum.
The differentiation is pulmonary edema. Is that
That's
not
correct.
right between
That's
class
correct.
2 and class 3?
That's correct. And class 4 is hypotension.
So what is exactly the rationale for continued use of the intra-aortic balloon pump if there's no, I guess, evidence of its efficacy, or there is evidence that it actually increases the workload of the heart? So
Based on what I discussed, there's probably no rationale. But I think, and what Dr. King alluded to, in probably an abrupt occlusion of the vessel or probably clip class 1 or 2, probably can tie the patient over. It probably help the psych of the interventionalist more than anyone else. But I think the correct devices are LV support devices, to be honest with you.
About acute severe MR.
Yeah. Sorry?
What about valvular disease?
So acute severe MR, yeah, but I think this except for acute aortic regurgitation, but the devices are not probably useful. The acute severe MR, the balloon pump is probably useful.
No, we still very frequently we see people with chest pain. We put a balloon pump in, and we're able to beta block them and put the balloon pump in. And maybe they're beta blocked already, but the balloon pump is very good at relieving pain and stopping the progression of ischemia. And so certainly from a clinical point of view, I think the balloon pump has utility in the CCU and in the post-op surgical ICU. We also repeatedly see patients who are trying to come off pump who've got MR that is 3+ MR. We put the balloon pump in, and it's 1+ MR. So to say that the utility of the balloon pump in frank cardiogenic shock is limited as far as relieving survival. But in those intermediate areas, I think the balloon pump still is a very useful tool, and we need not to forget about it. We also need to use a 50 cc balloon pump, though, in a big person, and not try to put a 40 cc balloon pump in a big person.
So I agree with Dr. Guyton. The important thing is that it does improve myocardial perfusion, by the diastolic augmentation of coronary blood flow in those kind of situations that you talked about. But the issue about resting the heart that we've believed does not.
Does improve. Does improve perfusion.
That's correct.
So it does improve the balance between perfusion and need, because it improved perfusion.
But the concept of resting the heart, I don't think is there. I mean, that it does not rest the heart as we originally thought it would do that.
Tanveer, the big decision, I mean, as people go into shock, you do something, right? I mean, or they crash in the cath lab. But the elective use, TandemHeart, you said it's very profitable to the hospital, which means it costs a lot of money for the rest of whoever pays for it. The question of how, and it has been marketed this certain places. We were told that this is great. You should put this in everybody because you make a lot of money. But usually in those settings, it's put in because then you're anticipating something bad happening, but I guess my question then will be, how often should you, or what circumstances should you use a tandem heart as a prophylactic maneuver?
I don't, I mean, tandem heart requires a septal puncture, and I don't use tandem heart. I think an Impella,
Excuse me, I mean Impella.
so the high risk criteria that we talked about in JACC intervention, the patient with low EF, patient with the complex left main disease, multivessel disease or left main equivalent, the surgical turndown patient, or the last remaining conduit who comes in for the high risk PCI. You should think very carefully about putting the device in that group.
So should we be using the Impella more in the operating room, and can it be put in under echo guidance?
People have done that. People put it under echo guidance, and certainly in those patients who you feel that may not come off the ventilator because of RV dysfunction, the new right side Impella will be a great added tool for you.
The preceding program is copyrighted by Emory University.